Hi again. Topic is dissections and blister aneurysms. Par definition, arterial dissection is a sudden disruption of endothelium, intima, and internal elastic lamina with penetration of the circulating blood into the media of the vessel. Pathophysiology of the dissections are unclear, but most of them intracranial dissections are spontaneous, maybe due to the lack of external elastic lamina and presence of the thinner media. But there are certain ethiopathology like trauma also can cause dissections. Mycotic or oncotic aneurysms also in the etiopathogenetic list. Vasovasorum issue is speculative, but I am interested in fusiform dissecting giant aneurysm. Pathophysiologies may be overlapping, but it is also unclear in science. This is an example of trauma case. Due to position of the fox and then the distal anterior artery, that typical dissecting aneurysm happen with an hematoma in the corpus callosum, and the treatment done in the parent artery occlusion by coiling, as you see here. Presentation of the intracranial dissections half and half with ischemia or subarachnoid space hemorrhage. Occurrence of both at the same time is rare. There may be, you may find a mass effect or intracranial hemorrhage as a morphological features of the pathology. Radiological diagnosis most of the time challenging because of the small size of the vessel, subtle non-specific finding, and suboptimal equipment, I mean diagnostic equipment and protocol. And also dynamic nature of the disease is creating problem for diagnosis. If you have a look at the vessel wall, MRI is the study of choice. With MRI, most interesting finding for me is the mural hematoma, as you see in here, or double lumen intimal flap. Most of the time, due to the size of the vessel, you may not see the intimal flap and the double lumen. Of course, enlarging focal local enlargement of the artery, especially in non-branching segment, is very important. We should aware that focal enlargement may be because of the dissection. I will explain this you later. Of course, when you see that the mural inflammation or hematoma as that popular that vessel wall imaging nowadays, there are a lot of differential diagnoses in the list. This is an example of dissection and the focal enlargement of the posterior cerebral artery P2 segment. Is the rupture case in 2007, but nobody want to touch this. Nobody described this as a dissecting aneurysm. But the mural hematoma maybe is an explanation of the dissection. In 2014, and it becomes like this. This is a perfect serpentine type of aneurysm, partially thrombosed in the same location. Parent artery occlusion done, and this is a second-year follow-up, and patient has fine because of the pile collateral is good enough to survive the occipitoparietal temporal region. But in those large giant group, again, I'm watching it, that thrombose homogeneity and the vasovasorum, especially the follow-up protocol on MRI should be with contrast media. If you like to check the vessel lumen, the growing puncture angiography is the gold standard. You can see the focal vessel irregularity or enlargement or Pearl and string sign means dilated segment with proximal or distal to the aneurysm. Tapered vessel lumen, stenosis or occlusion of the artery. Again, intimal flap and the double lumen can be seen in angio. Most interestingly, if the aneurysm is visible, that intramural pooling of the contrast medium is an interesting finding. And also, retention of the contrast medium in the aneurysm lumen is interesting finding. Intramural pooling can be seen in flat panel detector CT angiography during the angio. This is a nice example of the superior cerebral artery dissecting aneurysm, typical proximal and distal narrowing. Treatment is done by coming from positive communicating artery, going into superior cerebral artery and coiling. Another dissecting aneurysm, ruptured female, the aneurysm on the posterior communicating artery. The posterior communicating artery aneurysm coiled by preservation of the posterior communicating artery. It's a year follow-up. And have a look at the aneurysmal lumen stagnation in the angio. Even after having venous phase, you may see this stagnation. It is a kind of typical finding for dissecting aneurysm or acutely ruptured aneurysm, which covered by thrombosis. Management of the dissecting aneurysm intracranially, you need to intervene them. Otherwise, they re-rupture very quickly. And the vascular way seems one of the most safest and famous way of treatment with parent artery occlusion, sacral component occlusion by adding stents or balloon, or hemodynamic treatment, either flow reversal or flow diverter. Of course, there are certain cases we need to use surgery. This is an example of typical dissecting aneurysm on the posterior communicating artery itself with an infarction of anterior thalamic artery region. This is a very typical feature of the anterior thalamic artery, actually, which is arising from the posterior communicating artery. I also published this dissecting aneurysm, which is specifically located in that region. Aneurysms can be found everywhere. That this aneurysm, dissecting aneurysm, typical proximal distal narrowing on the lenticule artery with rupture and ischemia together. That two occurrence is rare, mostly seen on the perforating artery regions. Of course, the treatment done with occlusion of the aneurysm, because in 10 days, the size of this aneurysm is getting bigger. It is ready to re-rupture. Of course, by occluding the lenticule artery, you are for saving the patient life. Time to time, parent artery occlusion is done, even though you know that you will have an infarction. Interestingly, certain infradural aneurysm, dissecting aneurysm can cause rupture, mostly subdural hemorrhage, not the subarachnoid space hemorrhage. This is a typical location of dissecting aneurysm in the cavernous segment, petrocavernous segment. And of course, if you have a nice villus polygon collaterals, better to have an occlusion in such thinking to use flow diversion technology to reconstruct artery. But I'm still searching for parent artery occlusion. It is simple and very effective. In the dissecting group, you should be aware that it is better not to believe tough non-contrast MR angiography. Is the rupture case, the angiography is normal. There is nothing here. The superior cerebral artery is not seen in this examination. Even though this is a low quality of MR angiography, there is no visible filling lumen here. A week later, you can surprise by seeing such wide neck, ugly shape, aneurysm arise from this segment by occluding the superior cerebellar artery. This is a very nice morphology to understand that these aneurysms are different than regular saccular aneurysm because of the dissection. That dissection, the intima or media, can occlude the adjacent vessel, like in this case. This time in the acute stage, we do the balloon remodeling technique and in the collet. Please note that superior cerebellar artery is absent. And in those dissecting morphology, we're having early follow-ups. Like in this case, 3 months later, there is a perfect recanalization in that region with an appearance of the superior cerebellar artery, and also proximal superior cerebellar artery is in the aneurysm. This is a very typical finding. Look at the stagnation of the contrast in the aneurysm, very typical dissecting aneurysm. This time, treatment done with the balloon remodeling technique, and additionally, we deploy a stent to enhance the healing reaction. This region is stable, and preservation of superior cerebellar artery in a first year follow-up, most probably due to the stenting in the lumen, can create a healthy intima on it. How would you treat this one? This is again typical dissecting aneurysm with a proximal narrowing. There's another bleb here. All M1 segment is occupied with the fusiform aneurysm and rupture. There is also a calcification on the wall. It is also another indicator of something going on in the aneurysm wall. This may be a dystrophic calcification from previous rupture. Treatment done in this case, because there is no option to occlude this aneurysm with proximal portion of the MCA, you may lose all the lenticular area. That's why we choose the flow diverters with the scaffolding technique with Leo and Silk. Please have a note that this part is narrower than the other. Immediately after stenting, the flow change. And this is the second month follow-up. The aneurysm is getting smaller, but the proximal segment is still narrow. That is also an indicator of the dissection. But after 2 months, we are really happy to see this remodeling of the artery. This is a 3 years follow-up. Please again have a note that this proximal dissecting, because dissections start here, is antegrade flow with creating such big aneurysm. In 3 years, that vessel's totally remodeled, reconstructed. And please have a note that this is the flow diversion part in the Leo, intentionally not occupy the A1. In those paravenous polygon aneurysm, we are first checking the collaterals of the villus polygon. We are trying to not to occlude the anterior cerebral artery orifice with flow diversion. But if you have a nice collateral, you can cover it, no problem. Blister aneurysm morphologically or histopathologically resemble to pseudoaneurysm, especially on non-branching site. We can see those aneurysms everywhere in the brain. Real pathogenesis still unknown. But for blister group, I'm a strong believer of arterial dissection. First described in the late 70s, the term of blister was introduced by Takashi in 88. And initially, the classical definition is restricted to the internal carotid artery distal portion, anterior wall. But again, it can be detected any vessel in the brain. Up to 2% of the ruptured aneurysm is devoted to blister. There are morphological classifications like this, starting small and getting bigger and becoming circumferential. And this is a very nice example of the blister and a typical blister aneurysm location. In those groups, that transition, healthy vessel transition zone is unknown. And in 1987, balloon remodeling technique is done in a very short period of time. Look at the whole vessel become fusiform aneurysm. It is a typical example. Another typical example, typical location, please don't underestimate this focal enlargement. These are aneurysms, these are dissections, ruptures. And then most of the time I'm using stent. This is a stent coiling mentality I'm using for. I'm selecting softest coil, deploying it in the parent artery, not in the sac actually. This is a halfly deployed stent ready to deploy, and squeezing my soft coils by stent into the very weak wall aneurysmal part, creating such a coil shape, trying to cover the fusiform segment. And immediately after, you got this appearance. And these in this group, I'm doing an early follow-up. And an early follow-up with DSA or MR angiography. This is the DSA, shows the stability. And if you want to do the MR angiography, especially after stent, mostly you need to use contrast material to understand the stent lumen and then the peri-stent feeling of the contrast media. The tendency goes to the stent, especially the flow diverter on the blister like aneurysm in the world. Another typical aneurysm, please have a note that proximal portion has narrower than the distal. Flow diverter is placed. This is 3rd-month follow-up. Aneurysm is gone. Fusiform segment is gone, but still some narrowing in the proximal segment, but looks good. But when you check this long-term follow-up, this is 6-year follow-up of this particular case, as you realize, whole internal carotid artery, including the proximal narrowing segment, is remodeled. This is the beauty of hemodynamic treatment, especially in this fusiform dissecting group. This case came to me with a rupture. I thought this proximal bigger one is ruptured, and then I treat this with balloon remodeling technique. And this was my fault not to touch this one. But I decided and talked with the family to treat this blister-like aneurysm. But before treatment, she re-ruptured with an enlargement of the blister aneurysm. This time, again, the same technique, but the stent is flow diverter, halfway deployed, squeezing the coils into the rupture point, and then having this type of shape. This is a year follow-up. Stability and reconstruction of the parent artery by helping the stent. And this is a 3rd-year follow-up of this particular case. Indication in the acute stage mostly goes to blister and dissecting group. Of course, giant and fusiform aneurysm also included, but those the giant and fusiform group also most probably coming from blister and dissecting group. Of course, if there is no other better option. The data is accumulating in the acute stage, and then it is actually encouraging. But when you check the coil and clip group, flow diverter number are better than those group if the volume of hemorrhage is low and no hydrocephalus with a good clinical grade. Otherwise, the flow diverter numbers getting close to the stent assistant coiling. Of course, the rebleeding and then the anti-aggregation protocol can be discussable, can be changed team by team. Also, ventriculostomy timing is also inhomogeneous when you look all around the world. So-called benign perimesencephalic hemorrhage is nothing for me. There is no benign hemorrhage for my mind. If you check carefully, you may see that type of blister aneurysm. This is treatment done in flow diverter a year later. For sizing in this vasospasm period, before selecting, it is better to enlarge the vessel with nimodipine intraarterial and then do the stent. This case, the pregnant ruptured, again, the MR angiography and the normal angiography is showing nothing. But if you do a cone-beam CT angiography, surprisingly, you may see the mesencephalic perforator and then the fusiform aneurysm on it. That's why if we don't see anything in the angiography, this is my routine for all aneurysm, I'm doing it. This is a year follow-up. By chance, it is spontaneously occurred. Another blister aneurysm in the mid-basilar segment ruptured and the balloon remodeling and coiling, very early regrowth in 2 weeks. Second treatment done, again coiling this filling portion by adding the flow diverter. It looks great, but in 2 months, it came back to the regrowth with a mass effect in the brainstem, edema, and don't forget that there is flow diverter in that segment. Angiography show that jet flow. These are not seen in regular circular aneurysm. Look at the coils. That is very interesting. And the telescopically, the another flow diverter deployed, and 2 months, 3 months later, aneurysm occluded. 7 months, they shrink, and then the 2 year follow-up, will the coils turn back to normal position with a proper basilar artery. This is 6 year follow-up, as showing everything is normal. In this case, I decided to put two neuroform because in 2003 there was no much options, because I thought this enlargement is a dissecting aneurysm. That mentality always in my mind from those years. And then I deployed two neuroform stent. You may criticize it why you are putting neuroform in this spastic artery, but I did it. Look at the follow-up. It is showing that I am right. November, in April, very short, the aneurysm is happening in that location, 7 months later of the treatment. And then I go there and the balloon remodeling in the neuroform telescopic assembly and call it. And this is May 2005, and this is 12-year follow-up, still stable, which is also showing that at the very beginning, my mentality is right. We also published this is the first publication of the hemodynamic treatment with scaffolding technique. These are coronary stent and in cover stent. This is the jaw stent in the inflow zone. Look at the dramatic hemodynamic changes, partial thrombose, fusiform basilar aneurysm in 7 months. And this is the second year, 50-year and 15-year follow-up, shows the stability of everything. That's why those cases showing us we are in the right direction to play with the parent artery, not play with the dissected lumen, visible lumen. These aneurysms are bizarre. This is a headache, peer-rupture aneurysm, I believe. And I deployed the Fred Jr. here and look at the dramatic change of the angle that I like. Most of the small blister aneurysm, whenever you put the stent, any stent, you may see disappearance of it. This is a year follow-up. This is another typical finding for blister aneurysm for me. Disappearance immediately after the flow diverter. Very distal M5 segment, dissecting aneurysm, proximal distal narrowing, and stenting. This is the immediate first day and post-embossy disappearance of the aneurysm, first day. And this is 6-year follow-up, showing the stability of the parent artery and stents. I also published this, I show you from the Moon section. This is an example of distal dissecting fusiform aneurysm. Interestingly, most of the distal aneurysm are dissecting fusiform in nature or saccular fusiform in nature. Flow diverter, first year follow-up, and fourth year follow-up. Not always we are having success. It's a ruptured M2 segment or bifurcation dissecting aneurysm, partially thrombosed, treated with flow diverter. In second month, serpentine lumen happened in that thrombosed segment, reaching the normal vessel. We thought we are doing good, but not actually. In the fourth month, it ruptured and passed away. And we are not controlling all the things in the giant, large thrombosed aneurysm. Rebleeding is an issue, of course. The flow diverter, when you look to large and giant one, it is at least double, and posterior circulation more dangerous. Multiple standing, single stands also different. The complication rate in the flow diverter, this is in the literature. It depends on the team approach. I mean, anti-aggregation protocol. We're having little bit less than this number. But you should know that dissecting aneurysm group has more complication than the circular one. In conclusion, we are gradually increasing our treatment. We already increased, but we are still way to go on especially ruptured blister and dissecting group. No standard treatment criteria yet, but stenting is famous. Anti-aggregation protocol is discussable, and also surface technology will change this protocol. We need to find a way how to heal, how to control the healing reactions, but we need to have a further investigation. I would like to thank you again for the invitation. I'm inviting you to come Istanbul at the end of September for European Society International Aneurysm Cerebrovascular Malformation course. Thank you.